Hello everyone, myself Shaikh Aisha, tutor from the Department of Cardiovascular Technology, Yenepoya School of Allied Health Science. Today I'll be talking about the topic Pericardial Tamponade. So let's start with the specific learning objectives. By the end of the session, students will be able to know definition and types of tamponade, pathophysiology and diagnostic methods used and treatments modalities which is implemented. So let's begin with the introduction part. So basically we'll start with what is pericardium. So pericardium is nothing but a membranous sac or fibrous sac which surrounds the heart. So what is a function? Now the fluid which is present in the intrapericardial space, it helps by reducing the friction for which during cardiac motion. So let's begin with the anatomy part. Normally, a pericardium is composed of two layers, the outer layer and the inner layer. So the outer layer is fibrous parietal pericardium and the inner layer is serous pericardium. So let's move on to the definition. So basically this pericardial tamponade is a serious medical condition in which you can see there is compression of heart due to accumulation of fluid or accumulation of abnormal amount of fluid or blood in the pericardial space or intrapericardial space. So what happens in this is, due to this abnormal amount of fluid, you can see there will be reduced ventricular filling and subsequently there will be compromise in your hemodynamic function as well. So this was a definition. So let's move on to the etiology part. These are nothing but the causes why cardiac tamponade happens. The first one is idiopathic. The next one is due to acute MI, heart surgery, due to pericarditis caused by bacterial infections, maybe due to the injury to the heart. The next one is any recent invasive procedures were done on the patient, any radiation therapy to the chest, neoplastic or any kidney failure. These are the causes why pericardial tamponade can happen. So next we will move on to the types. So the first one is acute cardiac tamponade and the next one is subacute or chronic. So the first one is acute, in which occurrence, okay, this occurs within minutes. The next one is how much amount of fluid it can accommodate. It is rapid accumulation of fluid up to 100 or 200 ml. And this can be caused due to any trauma or rupture of the heart or aorta. So next we'll move on to subacute or chronic cardiac tamponade. The first one is the occurrence period. It occurs over a period of days or weeks. And the next one is accumulation of fluid. It is a slow accumulation of fluid up to 2000 ml. And it can be caused due to any infection or neoplasia. Next, we will move on to the pathophysiology. So what basically happens in cardiac tamponade, you have to remember is there will be increased pressure within the pericardium. So on inspiration, when a person inspires, what happens is your intrathoracic pressure decreases. When there is a decrease in your intrathoracic pressure, at the same time, there will be filling of blood in your right-sided chambers. Right-sided chambers is nothing but your RARV. So there will be increased amount of fluid which is getting filled in your RARV, that is nothing but your blood. So what happens now is, now as you know, as I said you, there will be increased pressure within the pericardium. So what happens due to this increased pressure, your RV volume limits the filling of blood into your RV. So now what happens, your RV free wall will not be able to dilate or not open up completely. So your IVS is doing the work here. Your IVS will bulge towards your LV. This was a pathophysiology on inspiration. So next, the pathophysiology will be on expiration. What happens? In the initially, the intrathoracic pressure increases here. On inspiration, it decreases, here it increases. So what happens is, at the same time when your intrathoracic pressure increases, there will be filling of your left-sided chambers. That is nothing but your LA and LV, and there will be increased amount of filling in your LA-LV. Now, as you all know, due to the increased pericardial pressure, as I said you earlier, your LV volume limits the intake of blood. So now LV free wall will not be able to bulge or dilate or open up for the blood to accommodate. Your IVS is doing the work. Your IVS will bulge towards the RV. This was a pathophysiology of expiration. Now the same thing in this picture, as you can see in inspiration, the second diagram on the right hand side, you can see in tamponade condition your IVS is bulging towards your LV, and on expiration your IVS is bulging towards your RV. So this was a pathophysiology. Next, what happens, the other conditions, what happens is there will be reduced in end diastolic volume, that is nothing but your EDV. There will be decreased cardiac output, and there will be decreased systolic blood pressure during inspiration. So now we'll move on to the clinical symptoms. What symptoms can you see in a patient when a patient is having cardiac tamponade? So the first one is, when a patient is having severe tamponade, you can see the main finding is chest pain. It is suggestive of severe cardiac tamponade. So the next one is dyspnea. There will be hoarseness of voice from due to compression of the laryngeal nerve, and you can see palpitation. So patient can also present with other symptoms such as tachypnea, hiccups due to esophageal compression, fatigue, cough, fever and abdominal pain. So now clinical findings. What findings you can see? The first one is Beck's triad. Then you can see tachycardia, pulsus paradoxus, that is narrow pulse pressure, tachypnea and pericardial friction rub. Jugular venous distension, that is due to elevated central venous pressure, and also you can see low cardiac output. So next we'll move on to what are the three things which consist of Beck's triad. The name itself says Beck's triad. The first one is hypotension, the second one is muffled heart sounds, and the third one is elevated jugular venous pressure. So these three things constitutes Beck's triad. So now let's move on to the ECG findings, what you can see in tamponade. The first one is sinus tachycardia. You can see also T wave changes such as inverted T wave, flat T wave or low T wave, and you can also see PR depressions. Now in this tamponade condition, there are such few findings which is very important, such as the first one is electrical alternance in the ECG, and the next one is low voltage. So what is electrical alternance? You can see the QRS complex in the ECGs will be of various amplitude, different amplitude, and it is also known as cyclic variation of QRS amplitude. So why this happens is, it is due to the excessive motion of the heart due to the fluid which is filled in the pericardial space. So this was about electrical alternance. Now we'll move on to what is low voltage. Low voltage is due to the fibrin or fluid which is present in your pericardial space. It acts as insulating effect. So because of that you can see low voltage in your ECGs. So can you see this ECG? The pointer which is pointing in lead 1, you can see there is cyclic variation of QRS complexes, as well as in all the leads you can see low voltage. All the indicators which are indicating V1, V2, V3, the first QRS complex and the second QRS complex, you can see there is a difference in the amplitude. So next we'll move on to the X-ray findings. The first X-ray finding is cardiomegaly, that is nothing but enlarged cardiac borders you can see, large globular heart you can see, and also there is a main X-ray finding, that is water bottle shaped heart. So now let's move on to echocardiography. So in this you can see is there will be echo free space between the parietal and visceral layer, and there you can also see fibrous strands which will be present in the pericardial space. So now there will be hemodynamic impairment, as I already said you all. In 2D and M mode wise you can see in early diastole and late diastole. In early diastole you can see there will be RV free wall collapse, and in late diastole you can see RA collapse. So this is a picture You can see in left side, you can see there is a tamponade as well as LVH, and in right sided picture you can see after the pericardiocentesis your LVH is present. So next echo findings, there will be presence of swinging motion of the heart in pericardial cavity due to the accumulation of blood or fluid. And the next one is, you can see there will be variation in RV and LV chamber size. Your IVC shifting will be there during inspiration, and your IVC will be dilated, and you can see loss of respiratory motion or respiratory variations as well. So now let's move on to the Doppler changes. The first one is exaggerated respiratory variations in right and left sided venous as well as your valvular flow. Inspiratory increase on the right and it decreases on the left. As you can see, mitral inspiratory changes should be at least 25 to 30%, and the tricuspid inspiratory changes should be at least greater than 40%. So in this picture, you can see there is inspiratory changes. This is a picture which consists of a cardiac tamponade in the left-handed side, and you can also see there is RA collapse. And right side, you can see that is a subcostal four-chamber view. You can also see effusion in RV side. So now let's move on to the effusive constrictive pericarditis. So this effusive constrictive pericarditis is nothing but a unique involvement of visceral pericardium. So in the patient with tamponade, intracardiac pressure remains elevated even after the pericardiocentesis is done on the patient. So let's move on to the treatment modalities which is used in cardiac tamponade. The first one is pericardiocentesis, the next one is medication to help increase the BP, and the next one is oxygen to reduce workload on the heart. So now let's move on to what is pericardiocentesis. Pericardiocentesis is nothing but a therapeutic and a diagnostic procedure in which the fluid is removed from the pericardium and the sac that surrounds the heart. So this is nothing but pericardiocentesis. Even the removal of very small amount of fluid also, such as 5 to 10 ml, also can increase the stroke volume by 25 to 50%, which in turn increases the cardiac output as well. So now indication. So the first one is diagnostic and the second one is therapeutic. In diagnostic, you have to determine the cause of pericardial effusion or pericardial tamponade. The next one is therapeutic. In this, there will be hemodynamic instability, cardiac arrest, and pulseless electrical activity. So let's summarize what we have learned today. The first one is pericardium is nothing but a membranous sac or fibrous serous sac which surrounds the heart. Compression of the heart due to accumulation of abnormal amount of fluid in the pericardial sac is nothing but tamponade, and even removal of 5 to 10 ml of fluid has the chances of increasing the stroke volume by at least 25 to 50%. So these are my references. You can, for further studies, you can refer these textbooks. Thank you.